Welcome to the Heartland Institute's special invitation-only COVID-19 response briefing. Return to normal, getting our states back to work quickly and safely. My name is Jim Lakely. I'm the Vice President of the Heartland Institute, and we're very glad you're joining us today to go over in more detail the COVID-19 brief that you should have received from us last week. The Heartland Institute is a 36-year-old national free market think tank based in suburban Chicago that specializes in exactly what we're doing this morning, being at the service of public officials, especially state legislators who need well-researched, sound, and successful policy advice. In this briefing, you're going to hear from some of the best experts in the country on what we need to do about COVID-19 and how to save America from this economic challenge, while also protecting those most vulnerable to the coronavirus. Both of these goals are achievable with the right policies. Before I hand it over to Heartland's Cameron Schulte and Anne-Marie Schieber, I want you to know that we are here to serve you throughout this crisis and beyond. This is Heartland's first briefing of this kind, but it will not be the last. Now, ideally, this morning's online event will be as interactive as possible. I will be serving as the host of this Zoom call, and we'll be monitoring the chat room and the Q&A section and looking for raised hands. So I'll be here relaying that stuff or your questions to Heartland staffers and participants. So don't be shy with your feedback. But let's get started in earnest now. I will hand the program over to Heartland's Director of Government Relations, Cameron Schulte.
Thanks, Jim. Good morning. Thank you for joining us this morning on this webinar. I'm Cameron Schulte, Director of Government Relations at the Heartland Institute. I want to first thank Anne-Marie Schieber for spearheading this policy report on reopening the economy and the many experts she worked with. She did an incredible job bringing it all together so quickly and produced a very thoughtful and well-done set of guidelines. We did this project because many states have varying degrees of openness, and there seems to be a race against time. Many legislators, some of whom are on this call and some who weren't able to join us, looked to Heartland, as they have done in the past, to provide thoughtful, timely analysis on this issue. This project provides a 30,000-foot view of guidelines and protocols that you as policymakers and opinion leaders can use as your states look to reopen their economies after unprecedented steps have been taken to curb the spread of coronavirus. Our next steps at the Heartland Institute will be to work with legislators in the individual states to assess the particular challenges you face, and then to translate that into actionable items. And after that, we will design a set of policies that can be instituted to jumpstart the economies of the individual states, from healthcare policy to education policy, to budget and tax policy, and even to energy policies. With that, I'd like to introduce Anne-Marie, a Heartland Policy Fellow, who will be presenting this morning. Thank you again for joining us, and if anyone has questions following the presentation, feel free to reach out to me at cschulte@heartland.org. Anne-Marie.
Well, good morning, and thank you for joining us. We have a lot of ground to cover and try to get all this material in an hour. But first, I want to introduce our terrific panel of physicians who are joining us, who helped us put together our list of guidelines and recommendations. I'm going to ask you to kind of raise your hand so we know who is who. Starting first with Dr. Jane Orient. She is President of Doctors for Disaster Preparedness and Executive Director of the Association of American Physicians and Surgeons. Dr. Jeffrey Singer is a surgeon and founder of Valley Surgical Clinics in Arizona, and he is a senior fellow at the Cato Institute. Dr. Chad Savage is founder of Your Choice Direct Care, a DPC, direct primary care practice in Brighton, Michigan. He's an internist and leading spokesperson for free markets in healthcare. Dr. Roger Klein is a physician and attorney, an expert on diagnostic testing who has been an advisor to a number of federal agencies on drug policy and regulation. And Dr. Marilyn Singleton is a board-certified anesthesiologist and attorney in Oakland, California. She is former president of the Association of American Physicians and Surgeons. So what we would like to do is go over our guidelines, which are 5 of them, and 15 recommendations. And we'll leave it kind of interactive. If any of our panelists want to jump in as we're discussing any of these items and want to give a couple of comments, just let me know and we'll stop. And then we'll give each of our panelists a few minutes after the slides to make a few comments if they'd like. And then I'd like to leave about 10 minutes at the end to go through some questions which we have already received. So with that, I will get started if we can get to our first slide. All right, so the Heartland Institute consulted with a dozen of health experts and economists to provide guidance to state and federal lawmakers on best practices for reopening their economies while protecting the public health. Everybody wants to get back to work, and we want to keep the public safe. The first thing is, slide number 1, is to acknowledge the knowledge problem. So knowledge is decentralized. If you follow Austrian economist Friedrich Hayek, he stated that decisions are best made by those closest to the problem. Top-down approaches can invite distrust and contempt for government. We're already seeing this in some rallies at state capitals. It's more effective to inspire people than to order them and coerce them. Number 2, setting priorities. Think what is safe and what is not safe rather than what is essential and not essential. A lot of states have made policy based on what they deem as essential businesses. And naturally, you have some businesses running afoul of the law and not others. Like, for example, in my state, Michigan, lawn service companies were deemed not essential, but if you cut down trees, you could go out and do business. And so a lot of that is a mystery to the public, and they don't understand. I think the federal government has recognized this decentralized approach for fighting COVID-19, and that is the best way to go. Number 3, assessing all the risks. Michigan is, where I live, for example, is looking at a way of tiering counties. In this particular state, as other states, a lot of cases are concentrated in metropolitan areas. In Michigan, for example, it takes 12 hours to drive from point A to from end to end. And so the needs in the 3 counties where all the cases are emerging in the Detroit area, there's no reflection. It's almost like living in a different state in the Upper Peninsula. So Michigan is going to look at putting counties in different safety tiers as they reopen. That might be one way to consider reopening states. Testing and protecting the most vulnerable. So states need to pay attention and put their limited resources in protecting vulnerable people who could likely require hospitalized treatment. Many people have recovered at home with minimal care, with good primary care even, with just their primary care physicians. We're going to talk a little bit later on, but to test everyone, as some people are advocating that we do, presents a whole new set of problems. There's capacity issues, and then the more people you test, the more possibility for false results. Number 5, getting restarted. And this is maybe a good way to think about it from General Patton, who said, a good plan violently executed now is better than a perfect plan next week. Time is of the essence. We need to get people back to work, and to sit and try to figure out the perfect way to eliminate a virus, which is an impossible goal, is really going to cause more damage than good. So let's go through the recommendations. We have 15 of them, and the first one is kind of alluding to what I just said. Is to be realistic. It's unrealistic to eliminate the virus entirely. Vaccines may take 12 to 18 months. As more people become infected, more people will likely have immunity, which will protect the population. Number 2, concentrate on problem areas. Statewide shutdown should be lifted immediately for all areas not clearly requiring quarantine. Shutdowns also raise constitutional issues and erode trust in government. Mass shutdowns create economic problems, which could lead to mental and physical health consequences. Dr. Singleton, you recently wrote an op-ed in which you cited a well-known statistic: for every 10% increase in unemployment, mortality increases 1.2%. Would you like to elaborate on that a little bit?
One of the things that seems to have been ignored is this definition of what's essential. And we have to redefine what's essential to life. And one of these things is the negative effect of unemployment, the negative effect of keeping people in their homes. Domestic violence we now have the numbers to show that it absolutely has increased. Child abuse has increased. Alcohol sales are up 55%. These are things that you wonder, were these even considered when the mass quarantine was instituted? And we're coming out with more studies that are showing that this older study, all the numbers are absolutely right. And heart disease, and it's something that was alluded to earlier in our discussion, that people aren't going to the hospital out of fear, and other so-called non-critical diseases, which seems to be these days, anything that isn't COVID isn't critical. And people are staying home and not having other problems treated.
All right, well, thank you for that. The third one is avoiding orders that are impossible to enforce. It is impossible to police everyone. Some people will run afoul of massive broad orders and not others, which leads to distrust in government and feelings of injustice. We want people to cooperate. We don't want them to resist because they feel like they're being unfairly singled out. And of course, we're turning our public, a lot of people in the public are afraid, and there's a lot of public shaming going on in social media, which doesn't make for very nice neighborly relations. And it's probably best to let people use their best judgment in getting back on the streets and into stores, restaurants, and other places that used to be open to the public. Before a lot of these shutdowns, businesses were doing this voluntarily. They were assessing their businesses. A small retail store doesn't have the same needs as like a large big box retail outlet where a lot of people are congregating. And so they can protect their customers as they see fit, and are probably the best ones to make decisions about what's a safe way for their customers to mingle. Number 4, monitor and regulate on the county level. So reopening counties where the incidence of disease has been shown to be of no great danger to the public health. Vast majority of counties in most states, again, a lot of the cases are in metropolitan, densely populated metropolitan areas. Number 5 is to monitor hospital capacity. Ramped up testing will undoubtedly reveal more cases of infection, but not all individuals will require hospitalization. Economic shutdowns should be warranted only if hospitals have reached or exceeded capacity. And Dr. Savage, you wrote about this recently, where this was the main reason for shutdowns, because we didn't know what we were dealing with, this mysterious virus. We didn't know what the demands would be on limited hospital space. And now we have real data. We're seeing how it's unfold. Do you want to talk a little bit more about that?
Sure. I mean, for a number of reasons, people were quite scared when this began and remain scared. And it's because of the unknown. We're looking into the shadows and we see, monsters lurking there, and maybe there are, maybe there aren't. But with the better data, we're shedding light into those shadows and seeing what actually exists there. Initially, the data was not accurate because we were getting bad numbers out of China, and our attempt to obtain the numbers ourselves were hampered by the lack of testing and the poor quality of the original tests. And what we had to see to base our decision making on was examples like Italy, where there was mass pandemonium, and the presumption was that would come to the United States. Well, now as we get several months into this, we're getting better numbers. And so now we can go away from hysteria to reasoned determinations of whether our interventions are appropriate. So we should be making adjustments as time goes by.
All right, and then number 6, which is protecting especially vulnerable populations. A couple of notes to be cognizant of here. People have a right to determine the level of risk that they are willing to accept, but those confined to care facilities are often impacted by the choices of others. So it might be wise to encourage designated visiting areas in group homes. Restricting workers from working at numerous facilities. I don't know, one of the panelists, maybe it was you, Dr. Singer, who talked about this. There are temporary workers who share, who I didn't know really quite how this operated, but they go from these group homes to provide care, maybe nursing assistants and so forth, and maybe that's just not a wise thing to do as we're trying to protect people who could end up in the hospital.
Well, that's the value of testing, of course. If we were able to get more, particularly antibody testing out there, where we could see if people have already had it and presumed immune, then of course we could be more flexible in who can work with vulnerable populations. But if you look at the data right now, approximately 20% of all of the deaths in the United States have been in nursing home patients. So we really need to be thinking about who can see patients in nursing homes. And furthermore, we ought to consider social distancing among hospital systems, so that, for example, and this is taking place in some cities, where you could designate 1 or 2 hospitals for all of the admissions for COVID patients, and try to keep the other hospitals COVID patient free. And that way you're not spreading the virus to non-COVID patients who happen to be in the hospital.
Good. All right. Judiciously, number 7, judiciously limit crowds. So in a crisis, it is justifiable for governments to limit crowds other than assemblies regarding government itself, which is unconstitutional. But this authority should be applied judiciously to ensure that the public health rewards are a net positive based on economic damage that such rules have already imposed and will continue to impose if left in place. Number 8, let employers and workers manage remote work. Government should let individual employers and employees decide what is best for keeping workers safe. Employers were already taking steps before states started imposing shelter-in-place orders, and they will continue to do so for a variety of reasons. Nobody wants their employees to get sick. And they also want to protect themselves against liability. So we should trust that they are the best ones in the best position to decide what is best for their employees. And the next slide, the same thing. I'd like to, 2 more points. Dr. Singer, you mentioned to us that there's no reason to believe if governors take their foot off the necks of their residents that people and businesses will suddenly be careless. And then I'll jump to Dr. Orion, who said, we talked a little bit about this. I thought it was interesting. You had an idea of letting businesses to bring in customers brag about the way they are protecting their customers. So Dr. Singer, tell us a little bit about what your observation is there.
Yeah, it's important to keep in mind that most of the social distancing actually that had been taking place took place before it was mandated by governors. South by Southwest, for example, canceled its event. Major League Sports was canceling their events. If you looked at the Open Table was keeping track of restaurant reservations, they were dramatically down as people were deciding they didn't want to go to restaurants. So, and many employers who had the kind of system where people could work remotely were telling their workers to work remotely. In fact, at the Cato Institute, where I work, everyone was instructed that they're going to be working remotely and not going into the building well before any sort of mandates were placed. So the important thing is that public health officials should inform the public of things they need to know. But generally speaking, an informed public will make the right decisions because they don't want to get sick or make their neighbors get sick. And when you have it being done voluntarily by the public on a local level, it tends to be much more flexible. It's much more easy to adapt or modify what you're doing as new situations and new information comes to the fore. Whereas when you have a one-size-fits-all mandate imposed by government, then trying to relax or adjust those mandates is sort of like trying to turn around a battleship.
That's a great point. Dr. Orion, I want to ask you about what we talked about earlier about restaurants. So this is one area that are really, bars are still shut down. Restaurants, it's going to be very difficult to restrict the number of people who come into a restaurant and still make it profitable. They run on very low margin businesses. And if you're going to tell people they can only have 10 people in their restaurant at a time, it's going to be difficult for them to reopen. So we talked about maybe perhaps you figure out ways to assure the public that they are safe so you can bring in more people. You want to talk about things like HEPA filters, other things restaurants can do to make to reassure the public that it's okay to come and spend money.
Well, the world is full of germs, and SARS-CoV-2 or whatever it's called is not the only one. You can get the flu, you can get a cold, you can get hepatitis, you can get all kinds of things in a restaurant. And maybe we should be thinking about exactly how is the illness transmitted. If it's transmitted in the air, well, we may have very poor ventilation in a lot of places. And maybe we should have better ventilation. We should run the air through HEPA filters, maybe have ultraviolet light. That's coming out as being effective for cutting down the viruses in the air. We could pay attention to where the main aerosols are generated, which is in the restroom. No better aerosol generator than flushing a toilet. Maybe restaurants could advertise their safety things by having sanitizer dispensers at each table. I think that and in hospitals, we definitely need to pay attention to things other than COVID. What about resistant Staph aureus? What about this awful Candida that's going about in hospitals? I think hospitals could be paying a lot more attention to good housekeeping, not to mix up the clean and the dirty linens in the same carts that go back and forth. Maybe replacing their stainless steel fixtures with copper, where microorganisms persist with much less time, and using ultraviolet robots to come around and clean the rooms, because hospitals really have a very serious problem with multiple drug-resistant organisms, and this might be an opportunity to address that basic problem.
Yeah, I was just thinking, we give tax credits for people for energy saving things that they do to their homes and their businesses. Maybe this is a chance now, since we are putting so much priority on good air quality, that maybe we expand what would qualify for an energy saving device and let them do things like HEPA filters. I don't know, just something to think about in the future. Let's go to slide number 9, contact tracing. So this is real interesting. And during the AIDS epidemic, in the interest of privacy, patients were not added to public databases. And now we're rethinking this. Now that's granted about 40 years ago in the 80s, when we didn't have the technology that we have today. But today, it's really easy to follow somebody's movements with cameras and contact tracing from cell phones. Today, a proposal came out by Scott Gottlieb and Slavitt, two former director of the Centers for Medicare and Medicaid, to do multi-billion-dollar contract tracing. So one idea would be a common sense idea is to make this voluntary instead of coercive. Let's go to number 10, which is pretty self-explanatory, reopening public parks. So this, I think, was a surprise to a lot of people why parks were shut down, and I think it was due to crowd control, certainly in highly populated states where beaches and parks where a lot of people congregate. But studies have shown that outdoor COVID-19 dissipates rapidly in the outdoors, especially if there's wind. Dr. Orient, you mentioned there is a way to control large gatherings of people. Just take out a bullhorn and tell people to break up. Do you think that would work? You live in a big state for parks and tourism. Is that a problem if we open our parks?
Oh, I think for people to go outside in the sunshine is extremely important. The ultraviolet light from the sun not only kills viruses very quickly, but it helps you make vitamin D. And your ability to resist respiratory infections depends on vitamin D, and most people are deficient in it. So there's no better thing than being out in the sun. And to say that being 3 foot from a person is dangerous and being 6 foot from a person is not, it's not evidence-based. I mean, that's somebody's opinion. And it sort of depends on a lot of things. And if you're out in the open, it's far, far less of a problem than if you're in a tiny, poorly ventilated room.
All right. I think that makes a lot of sense. Slide number 11. Reopening hospitals and doctors' offices, and perhaps our panelists will all like to comment on this, because we talked about this briefly. People have not been able to get elective surgery, even go in to see their physician for problems that could become bigger issues without medical care. We're doing a lot with telemedicine, but sometimes you need to go in and get treatment. And we have hospitals that are laying off people because that was a big source of revenue and ways they could keep their doors open. Does anybody want to talk about that?
I'll jump in for a second. I'm the surgeon on the panel, so the ban on elective surgery has impacted my practice directly. Elective is oftentimes thought of by people as being unnecessary. It's not unnecessary. It just means that it doesn't have to be done this moment, that it's not an emergency. It can be planned and scheduled. So, and there are a lot of patients in my practice and other surgical practices who are getting delays in, for example, diagnosis of possible cancers because they need biopsies done or further investigations which require surgical intervention. And even when you're not dealing with the prospect of cancer, you have a lot of people who are actually in a lot of pain, suffering because they're having a delay in their elective hernia operations or gallbladder surgeries or other surgeries for non-malignant problems. So just because it's elective, that doesn't mean a lot of very important healthcare issues are not being addressed. Even when you look at it, non-surgical people who, for example, are in need of getting cardiac catheterization because there's a concern about them having coronary artery disease. And how many people are not undergoing these non-emergency cardiac catheterizations that are ticking time bombs with regards to heart attacks that are not being diagnosed. So I think it was a mistake to ban elective surgeries. In the past, this is not a new thing. It's very common, for example, for we doctors to get contacted by our hospitals when the CDC's informed them that they're anticipating an unusually bad flu season. And they'll tell us, we're expecting that we're going to get a real surge of patients, and we ask you to please be much more judicious in your use of our facilities, prioritize what elective surgeries need to be done now and which could wait for a few weeks. And we do that because obviously we don't want the hospitals to be overwhelmed. But when we're given it that way by the hospital as a suggestion as opposed to a blanket ban, then we're able to number one, make our decision as to what can wait a few weeks and what doesn't have to, and what has to be done sooner. And also, as we witness on the ground that the surge has started to abate, we then don't have to get permission to start doing more of our elective procedures because we could see that we can start doing that, as opposed to when you have this rigid imposition of a mandate.
Yeah.
Do you think there's enough personal protection equipment out there? Yeah.
There doesn't seem to be a problem with personal protection equipment in the ORs. That's not been an issue.
Yeah, and if I can just jump on and add to Dr. Singer's comments, I'm a primary care doctor, so I offer the other perspective from the other side, and he is absolutely right. This has actually been an absolute devastation, this broad-ranging prohibition, and it is going to impact people, if not now. We're going to see this in the future. They talk about a secondary wave coming, and perhaps we'll see that with COVID-19, but we will see that with consequences of these broad-ranging shutdown of our healthcare system. There's a firm belief, because they found so few MIs, myocardial infarction, heart attacks in the hospitals right now, that there's a belief that people are sitting home with milder heart attacks and not seeking care. Now, you may think, well, good, they lived through it, so they're fine, but that's not true. Part of their heart dies when that occurs. And why that's a concern beyond immediate death is that that leads to heart failure in the coming months or years, and those people will die from that heart failure. So we will see for months and years to come the ramifications of these decisions. In fact, I have a patient, talking about essential and non-essential. The reason we have medical degrees is to deal with that kind of ambiguity, and we need to be allowed to do so. I had a patient in early March who was hospitalized with a GI bleed, but because her blood counts were relatively stable, they said, well, this is non-emergent. You can go home and we'll schedule your colonoscopy for 2 weeks from now. Well, she was discharged right about the time all the shutdown started to occur. Well, her hematocrit, her blood count was dropping. So I called the gastroenterologist. I said, we really need to get her in. 2 weeks is too long. They said, oh, we're sorry. She's been rescheduled to mid-May. I said, this is ridiculous. Not only are you now going to saturate the ERs with potentially COVID-19, but you're going to have all those people who could have been cared for by myself, by the specialist as an outpatient, who now their only way to access care is through the emergency department. And just this morning, guess what I got a notification of? She is now in the hospital with profound anemia, undergoing emergent colonoscopy, when this could have been done a month ago.
Wow. All right, I want to jump ahead because Dr. Klein, I think you may need to leave early. I don't know if you can hear me. My name is underneath your picture. But I want to talk to you before you have to go about testing. So if we could skip to, we're going to come back, but I want to jump to slide 15. If we could do that. Recognizing the limits of testing. I want to talk to you about that. So this is getting a lot of attention in the media, and there's this expectation that we need to test everybody to be able to function safely. Would you like to talk about the limits of testing? What is a realistic expectation? And talk about antibody testing and how that could play a pivotal role.
Yeah, hi, Emily. Thank you. So we're talking about two different kinds of testing: diagnostic testing for people who are acutely ill and have the disease, and then antibody testing, which shows a response to the disease, and they may or may not be acutely infected. So first of all, the notion that we're going to test everybody in the United States to see whether or not they have a COVID-19 illness is completely unrealistic and unnecessary. It couldn't work because you couldn't do everybody at the same time, and of course you can get an infection 3 days after you're tested. In my view, what we need to do is we need to start managing this like other illnesses, the same way we would manage a severe influenza outbreak, in which case somebody would get sick, they would go to their physician, we would test the individual, and we would see whether or not she or he was positive, and treat the person appropriately with isolation, for example, and perhaps monitoring or a quarantine of contacts, depending upon the situation. So that's how in my view, we should be moving toward using testing. There's been a lot of misconceptions about diagnostic testing, one of which is that we lack capacity. In fact, it's quite the opposite. The largest commercial labs in the United States right now have plenty of excess capacity, as do many academic medical centers. So there's lots of capacity. There's been some issues recently with collection materials like swabs and that sort of thing, but I believe those are resolving. Antibody testing is an interesting concept. What an antibody will show you, what these antibody tests show you, is whether or not you've been exposed to the virus, has been infected. And they normally have two different types of antibodies. One that'll show whether or not it's recent, and the other whether or not you're basically over it. These tests are valuable for two reasons. First of all, they give us a way to epidemiologically understand the disease, understand how severe it is, who's affected. We can monitor it, and we can understand how many people have it. Very, very important, essential. And we're seeing antibody tests come out of two recently come out of California, one in the Bay Area, one in Los Angeles, and then Governor Cuomo recently announced a study in New York, all of which, by the way, showed many, many more infections than actual cases, suggesting for most people this illness is actually very mild.
Right. So that test, case you're talking about in California, it suggests that the death rate is under 1%, because now we know that there are more people who have been exposed to it.
Yes, and that's true. So there's absolutely no question that the fatality rate for an infection is dramatically lower, at least in order of magnitude lower than or tenth lower than was originally presented. This should have been obvious, because our case definitions were based upon the sickest people. So we looked at the sickest people, and the disease looked like the sickest people. We tested only the sickest people. Now that we're testing a much broader range of folks, we're understanding there are many, many more infections. Most people don't even know they have it. In fact, something was just released with prisoners that it's rampant in the prison system. 96% of prisoners don't even realize they're infected right now. They're asymptomatic. As was Rand Paul, he said he would have never known he had it. So I think we need to understand what this really is. That the antibody testing is playing a big role in that. Even in New York, they showed 10 times more infections than cases. The other way you can use it is to test individuals and to see whether or not a person has been exposed, and to try to estimate at least whether or not they have some level of immunity. It's likely they do, because they got over the infection. We don't know how long lasting or how extensive that immunity is, but certainly there's some level of immunity and some level of protection. These tests many of them perform extremely well, but they're a little different than the diagnostic tests in that they have some of them have a small opportunity for false positives. So if you test a population in which there's very little exposure, you can get false positives that are more pronounced numerically relative to cases or infections than you would in a place where the infection is much more prevalent, like New York. One of the ways you can actually deal with this is you can test with a different method, what's called an orthogonal method. You can use another antibody test that uses a different method. So if somebody's positive, you can test them again, and that would go a long way toward eliminating a lot of the false positives that people are concerned with. And once people know that they've been infected, they probably have some level of immunity.
Well, those are all excellent points, because this issue is getting a lot of attention in the media, and there's a lot of misinformation. So thank you for.
As long as we're talking about tests, I wanted to make a point, if it's all right, regarding the regulatory aspects of tests. Most countries, well, not most, many countries have what's called reciprocity. So, for example, if a drug or a test is developed in one of the EU countries, it's recognized in all the other EU countries. So if the French equivalent of the FDA approves a test, it doesn't have to get approved again by the German equivalent of the FDA. It's granted reciprocity. Likewise, New Zealand and Australia grant reciprocal approval to any US FDA approved drug or test. I think Singapore as well. We don't do that, unfortunately. So when all these tests were already proliferating in a lot of other countries, the FDA regulations essentially granted, for all intents and purposes, a monopoly to the CDC, which then got a defective test out and lost very valuable time in getting these tests out. Finally, it was mid-March that the FDA relaxed regulations enough to almost kind of mirror what they're doing in other countries, and said every state could decide what tests it's going to allow within its own states. And that's why we're seeing, for example, in states like California, New York, Florida as well. University of Miami just came out with a study. The states are approving their own antibody tests as well as PCR tests, and that's why testing is picking up. And just recently, the governor of Maryland actually had a plane load of tests coming in from South Korea, from a South Korean company, because the governor has been given the authority under these relaxed regulations to decide what tests are going to be allowed in his state. So number one, the states now can take advantage of reciprocity and approve tests that are being used in other countries effectively in their states without having it to go through the FDA. And I would urge these states to fight to hold on to this delegated authority and not let it go back to the centralized bureaucracy of the FDA once this crisis passes, because this is what will allow much more readiness on the state level next time there's another pandemic.
Yeah, so Dr. Singer's right, and I would elaborate on one point. What had happened here was laboratory developed tests developed in hospital laboratories across the country that are commonly used in molecular testing, for example, are not regulated by the FDA, and the FDA claims the right to regulate them, but exercises what's called enforcement discretion, so it doesn't regulate these tests. And what happened was, when the emergency use authorization, or when the public health emergency was declared, when Secretary Azar declared the public health emergency, FDA incorporated laboratory developed tests under its emergency use authorization policy, which allows the FDA to take unapproved devices and let them on the market. And so by doing that, it essentially upped the level of regulation and more or less closed out laboratories from testing. And it really delayed our understanding of the disease. For example, in Washington State, where there was where the first instance of community spread was identified, University of Washington had a test ready to go for weeks. And the FDA prohibited them from using it. It was also true in New York. There were a number of labs that wanted to test in New York, and FDA was blocking testing from hospitals that were setting up their own or validating their own tests, and that's actually changed. So I want to say that the changes that were made resulted in an explosion in testing. And they also were difficult in terms of allowing test kits from reputable manufacturers on the market. Now you have plenty of tests that were approved under emergency use authorizations. There are analytically validated. The data is all on the FDA's website, so you can look at those tests. You can look at their functional performance. They went ahead the end of February. They allowed the large commercial labs to test. They're saying we're testing 5 million people, or there's been 5 million tests. It's probably much higher. They're saying 150,000 a day. It may be 200,000 a day. There are so many places testing. Last I looked a couple weeks ago, we had over 600 labs testing. So I think that the relaxation in regulations to make it more reasonable to fit the situation helped enormously, and we've really had an explosion in testing. As a pathologist, I have to say I'm very proud of the laboratory community and the work that we've done. What we have done in the United States, both the manufacturers, the testing laboratories, and everybody working together, both big and small, is nothing short of miraculous. And I agree with the president, by the way, who has praised the testing efforts, and really, again, we have excess capacity now in terms of the laboratories. We're not behind in that area.
So imagine what the private sector can do when you let it. I want to back up and talk about one really important point before we get to our Q&A. We're not going to be able to cover all the slides, but this is another really important issue, somewhat related to what we've been discussing, which is slide number 12. Let physicians treat their patients. I know you all have thoughts on this. Maybe we can jump to you, Dr. Orient and Dr. Singleton, as we talked about, you just wrote an op-ed on this, Dr. Orient, about the states. I was really surprised to find this out. Only 4 states are not getting in the way of physicians treating their patients as they see fit. Can you talk a little bit about some of these restrictions and why they're misguided?
I think this mainly refers to hydroxychloroquine, an anti-malarial drug that's been around for decades and is really quite safe as drugs go. The FDA put out an emergency use authorization for this, but instead of making it easier to use this drug, which is perfectly legal because it's been approved, it's just an off-label use, they have said, well, this shouldn't be used except in hospitalized patients who are preferably on a randomized controlled trial. Well, this is the time when it's least likely to be effective, most likely to be dangerous. And here we have people dying, and we are threatening doctors with loss of their licenses in many states, all but about 4 of them, or pharmacists with loss of their licenses if they prescribe this drug. Sure, there are risks and benefits, as with any drug. That's what we go to medical school to learn how to do. So I find it just really, really outrageous that we are trying to squelch efforts by physicians to help their patients, particularly prophylactically. You know, we talk, we're going to have a vaccine, we're going to have a vaccine. Maybe in 18 months we'll have one that we can manufacture and distribute, and maybe we won't. We've been working for a malaria vaccine for decades. So we have used these drugs prophylactically for malaria. And now we're sending our healthcare workers and contacts of patients who are maybe taking care of a person at home out into the field without something that could drastically reduce the carnage from this illness. And then they're also attacking doctors who use intravenous vitamin C, and there's plenty of evidence from all over the world and decades that this can be very, very useful. I mean, why is the government preventing the practice of medicine?
Right. Dr. Singleton, would you like to add anything to that?
Well, yes, when it comes to hydroxychloroquine, there is really a bizarre political aspect to this. Even the CDC, back in 2004, when the first SARS virus came out, did experiments on it and found that hydroxychloroquine was useful both before and after exposure to the virus. In India, with its 1.3 billion population, what do they use? Hydroxychloroquine as prophylaxis. And they don't even make the curve as far as cases and deaths. Yet somehow we're told not to look at that we're told, oh, it's only anecdotal. It's not anecdotal at that point. And if we wait for the randomized double-blind study, more people will die. And as Dr. Orient mentioned, they're focusing these studies on patients who are already in the hospital and some already on the ventilator. And the studies are now showing that 90% of people on the ventilator die. So I don't care what drug you gave them. If they're already on the path to death, it's not going to work. So these are specious studies. And if we're going to do a study, it needs to be done on people who are mildly to moderately ill.
Can I chime in as well on that?
Yes.
Can I chime in?
Yes.
I don't know personally whether or not we're going to find out that hydroxychloroquine is effective. I think it does make sense before saying that outright to see what the studies show. I, of course, believe in the right of doctors to be able to practice medicine and to discuss the risks and benefits of off-label use of a drug with their patients. So I don't think the government should be inhibiting or interfering with doctors trying hydroxychloroquine on their patients. One thing that particularly disturbs me, though, is just in the last few days, we heard the FDA issue an advisory, I think it was the FDA issued an advisory saying hydroxychloroquine should not be prescribed in a non-hospital setting because it could have dangerous cardiologic consequences. And this disturbs me because thousands of people are using hydroxychloroquine in the non-hospital setting. It's called Plaquenil. They're using it for rheumatoid arthritis, lupus, and other rheumatologic diseases. And they've been taking it for 50 years. And we have not heard of any significant cardiac problem. We know there are some cardiac problems, and it's the role of the doctor to decide who is a bad candidate for the hydroxychloroquine and who isn't, and how to monitor it. But this has not been a problem. And I'm afraid that the media attention to that recent advisory from the FDA could lead a whole lot of people who are getting good relief from their rheumatoid arthritis or lupus from Plaquenil to get frightened into not taking it anymore.
Right. They seem focused on one death, which was an unusual, crazy circumstance where somebody was really totally misusing it and using it really as an attack.
But it has been used in the ambulatory non-hospital setting for 50 years, and people are on it for long term.
Yeah. Okay. All right. So we're quickly running out of time. We've got about 9 minutes left. I want to get to your questions and answers. Jim, do you want to start with some of the questions that are coming in and see how our panelists want to respond?
Sure. I'm going to try to actually, Tony Randolph has asked a question. I'm going to try to allow him to talk so he can so he can ask his own question. And if that doesn't work out, I have it written down. Tony, can you go ahead and try to speak, see if we can hear you? No, I'm trying to unmute him. And
can you hear me?
Yes, Tony.
Yeah.
Go ahead, right ahead.
Okay, there we go. So my question was, essentially, with what I call the 50-foot leap and then having to what should be backtrack a little bit because it's not as severe as they had initially thought. Reports that are coming out that this is not what they thought it was. The numbers aren't going to be what they thought it was going to be. So based on some of the conversation earlier about doctors not being able to treat their patients, hospitals not basically the, what was it called, the non-emergency surgeries and things of that nature. But as you guys said, a lot of critical health issues are out there right now and not being able to be treated. So the question is, do you guys foresee some type of repercussion concerning that because of the large leap? Do you understand what I'm asking?
Yes. I'll chime in. Absolutely, there's no question. People are avoiding physicians and avoiding medical care, as everybody on this panel has mentioned. I have friends in New York who told me they're so frightened people won't go out of their house. I mean, they won't go to the doctor, as we've heard people may be sitting with mild heart attacks at home who could get arrhythmias. I think there's absolutely no question that we're going to see other types of health problems that will arise from what's taken place here. And it's just going to be it's going to be later that we're going to end up quantifying those, and we're going to end up balancing them. I think I think an essential point is, and it's what we really don't know. We really don't have data saying that these extreme levels of lockdowns themselves are saving anything. Saying that we're going to make sure we don't get a lot of infections at the same time, so that we don't overwhelm the hospitals, is very, very different than saying that we're going to actually save any lives from this. And we don't have data or evidence to suggest that is the case. So we may in fact be harming a lot of people without saving anybody. And I think it's important to understand that we don't have those data.
Yeah, and another important thing to recognize is that if you die from COVID-19, we will be able to quantify that. It will say on the death certificate that the cause of death was COVID-19. But if you die from a consequence of the intervention to prevent COVID-19, it will never say that on your death certificate. Perhaps you're sedentary in your house and you get a blood clot. It will say you died from a pulmonary embolism. It will not say you died from so we may never be able to fully quantify the damage that the intervention has caused.
Okay. We skipped over one slide, and which is reopening the schools. And I think this probably would bring us to a question maybe to wrap it up. So from Bill Henderson, in your view, what would be the next best step for states and communities to reopen? And if you can include in your comments any words about reopening schools.
I just like to talk about what I learned from watching an interview of Dr. Anders Tegnell, who is basically the one running the Swedish response in Sweden. He's sort of the Swedish equivalent of Anthony Fauci. And in Sweden, they closed the high schools and universities and had everybody continue classes online, but they kept the primary schools open. And when asked about that, he said, well, public health includes more than just considering the virus. And we know enough to know that the very young seem to be relatively protected from this virus. Either they don't get it or they get a very, very mild case. And the early developmental years are crucial in this age group, both from cognitive development as well as socialization skills. So he said, we just decided that it was the benefits, rather the risks of depriving these children of this crucial developmental period in their development they outweigh any risks of them getting coronavirus. And in addition to that, if they have to stay home, then their parents have to stay home to homeschool them, and they can't go to work. And many of them may even be healthcare workers. So they decided to do that, and they haven't seen any increased incidence of the viral infections in the children in their country, nor in the young parents who take care of their children when their children come home from school. So at the minimum, I think that's something that should be considered. You know, when you make public health interventions, there are lots of things that play into public health, not just one thing. We tend to be narrowly focused on a virus. There are so many other factors that need to be weighed when considering what's the best approach.
I've got a quick question. I know some of you are attorneys on our panel as well as physicians. Somebody asked whether, Phil Jensen asked that states cannot sue the federal government over this. However, it appears that counties and cities can sue their states. Does anybody have any thoughts on this? I haven't read anything that this is taking place, but some communities are really impacted by this. I'm wondering.
I'm not sure about the counties and the states. I can tell you that individuals certainly could sue, and they could raise it as a defense and an enforcement action. And that question, it would be a constitutional question as to whether or not rights were deprived. And really what would have to happen would be a court would need to balance under strict scrutiny whether or not the measures under police powers that the state took were justified. In Ohio, we had a situation where our governor canceled an election, and there was a lawsuit filed over that, and the lower court actually ruled against the governor, and we didn't have the election anyway. But so that sort of it just kind of was resolved by not through the litigation, but just by circumstance and the temporal nature of it. But anyway, yeah, I mean, right now, I think states are in a position where they're going to, and cities and town, they're in a position where they're going to need to justify these restrictions on individual freedom, restrictions on religious freedom, all of these constitutional rights that we have. They now individuals can raise those certainly in a court, and a court could say you've overstepped your bounds, state. You don't have justification for these extreme measures.
All right, well, we are running out of time. Is there one state who's kind of a model of the way to handle reopening? Does anything stick out in your minds? It's doing it right?
It appears that South Dakota never really closed. And they have their one outbreak in the pig factory, the meat processing factory, but nowhere else. And it's difficult sometimes to compare states, and that's the glory of federalism, is South Dakota is not the same as California, with masses of illegal immigrants that no one can keep track of, and huge urban areas. So in that case, it's difficult to compare state to state. And so what seemed to work in South Dakota may not work in California, although this idea that was mentioned earlier of county to county plans makes much more sense. Northern California, above Sacramento, is farmland, forest land, people living far apart from each other in the first place. They would have a different plan than Los Angeles. And we have to open that up.
Dr. Singleton, I understand there are certain counties in California that have no cases and never had. Am I correct about that?
Absolutely. Well, it's almost like here we're at the end of the thing, but don't even get me started with California. We have 40 million people here. And 1,200 deaths from COVID-19. What's wrong with this picture? That we're totally shut down,
Yeah.
and not very many cases considering we have 40 million people. And so the reaction is a political one more than a realistic one, and that's what's very sad about this entire response.
Well, this has been a phenomenal discussion, and I think a lot of people will appreciate all the great thoughts that you've shared with us today. Jim, do you have any words to wrap up?
I do. I actually have my own question, and if we can maybe get it get it in just a few minutes. But in your opinion, doctors, I mean, is the people that want to keep us locked down say that it is a medical necessity to do so, that we're going to be putting too many lives at risk, that we could risk a second wave of this if we open too soon. I wonder if some or all of you could briefly just comment on that. I think a lot of our viewers right now are kind of wondering that big question. How much of a risk is it if we do open back up and just do social distancing and not lockdown anymore? And, will they be held accountable, and should they be held accountable if we do have a second wave, and would it be blamed on that?
I think, of course, we're going to have a second wave because we haven't allowed the virus to reach as many people as it needs to before herd immunity is achieved. A lot of people have been criticizing Sweden because it has a higher mortality rate than its Scandinavian neighbors, even though it's right around the middle for all of Europe. And Dr. Tegnell said, why don't you take a look at the numbers in about 6 months, because the other Scandinavian countries are going to have their second wave and third wave, and we're not just having one gradual wave throughout, because the fact is that this virus is now part of our ecosystem. We cannot escape it. Years after we thought polio and measles were eradicated, we're still seeing cases show up even more frequently. So the fact is, this virus is with us, and instead of having the focus of attention being on not catching the virus, the attention should be focused on minimizing the risk to vulnerable people, the people who are much more likely to have a bad outcome were they to get the virus. And of course, allow that to be done as much on a local level by private voluntary action, which is the most flexible way of not only dealing with the problem, but making adjustments along the way as adjustments become necessary.
It's interesting too. People forget that politicians are humans too, and they're motivated by self-interest as well. So it's actually, I give the Georgia governor quite a bit of credit. Whether he's making the right decision or the wrong decision, no one actually knows right now. Only time will tell. But all of them are motivated by self-interest. So it's really hard to be the first one to go out there. And if it goes poorly, he's going to have a substantial political price to pay, and they all know that. So I think many of them are exceedingly scared to be one of the first states to jump on board with that.
So I want to just, I would reiterate what Dr. Singer said. This infection is simply too transmissible, and there are too many mild and asymptomatic cases for us to believe that confining people to their houses is going to eliminate it. I wish it were true. I hope it's true, but it seems like wishful thinking. What we're really doing is we're spreading out infections that are likely to happen anyway. And again, as Dr. Singer suggested, because I do believe we can help protect ourselves on an individual basis, especially, I think taking measures, very strong measures, and devoting efforts toward trying to protect those who at highest risk would be at least as likely to save lives and would probably save more lives than this sledgehammer approach. For example, nursing homes, just taking extraordinary measures in nursing homes to make sure that it doesn't get in and that they're exposed. We can all protect ourselves. We can implement rational and reasonable public health measures in ordinary settings, just as we do all the time. But we're not going to, or we're unlikely to achieve much over the long run by locking ourselves down, other than destroying the financial health of millions of Americans.
All right. Well, we got to most of our questions. If we didn't get a chance to answer your individual question, email it to us, and we'll try to get you an answer. Thank you all for participating. Thank you to our panel for your excellent ideas and thoughts and your time. And Jim, do you have any final words before we wrap up?
No, I would just say that everyone here, we have your email. We're not tracking you, but we do have it, which means we can give you the slides from this presentation. And this presentation has been video recorded. And unless there's an error with it, we'll be able to share that with you, so you can share that with others. And we hope to do a lot more of these in the future. We appreciate your constructive feedback on what you thought of this and how we can do it better. And that's we look forward to doing it again.
All right. With that, I guess we'll say goodbye. Thank you all again.